Good evening and welcome from Indian Rheumatology Association. This is our second webinar series and we had a very successful meeting in the last month. Hope you have enjoyed. They like this one, and this is on spondyloarthritis. So COVID has given us a challenge, and through that challenge we could explore and we could come with a very good projection, academic bowl, where we are having both international and national faculties, and we can have a very great learning with an interaction. So today, Dr. Dharmanand and Dr. Ashok Kumar are two moderators. They will check up the components as we have planned. Professor Amita Agarwal is there, Dr. Dharmanand is, Dr. Ramesh Joesh is there, Dr. Barun Dhir is there, and Ian McInnes, with the president of ULAR, is there today's program. And I want to mention another very great achievements from Indian Rheumatology Association, that we have just started a case of the month components in our IRA website. That's very exciting, and the young people specifically would love to interact there, and they can have their thoughts and they can have their issues through that one, and you can enjoy that one, I think. And to create this one, Padmanabh Shenoy, along with Shanket and Avinash, has done a marvelous job. That's really, we are so thankful to all of them, especially the two young people, though Shenoy is also another young at this moment. So I think we'd all love to enjoy that one, the case of the month. So can we have inauguration of the case of the month as well at this moment? Shenoy. Great. Thank you so much. So may I now hand over the podium to Dr. Dharmanand and Dr. Ashok Kumar to initiate the program. Thank you.
Thank you, Dr. Alkindu Ghosh. I would like to take this opportunity to not only welcome all the participants, including the audience, but also to compliment the president of IRA and the honorary secretary, as well as the team led by Dr. Padmanabh Shenoy in creating this great program. It's a wonderful initiative, and all of us are appreciative of it. That's what I want to say. Now, for today's program, we have 4 speakers, as you know. So what we have decided is that the first 2 talks will be moderated by Dr. Dharmanand from Bangalore, whom everybody knows. I really don't need to introduce him formally. And he will take over, and then the next 2 talks I will be moderating. So over to Dr. Dharmanand.
Good evening. Welcome, everybody. The first speaker is going to be Professor Amita Agarwal, and we all know her. And she is the current head of the Department of Clinical Immunology in SGPGI, Lucknow. And she was our ex-president. And she's going to talk about the hot topic, the bugs and the gut. And gut microbiome has dominated the field of science in almost all field of medical science in the last maybe 5 years to a decade. Over to you, Dr. Amita.
Good evening, friends. So I'm going to discuss with you today gut microbiome in spondyloarthropathy. And before we start, there are some basic facts which all of us need to know. That gut is a organ which has maximum surface area of around 300 to 400 meters square, with which it interacts with the environment. And we have more than 10 to the power 14 microorganisms in it. If you see, 99% of the genes in us are actually of microbial origin, not of the human. That is why the gut microbiome is called a super organism in the human body. The gut microbiome, as defined by the molecular biologist Joshua Gladberg, is actually the totality of microorganisms. We generally talk of bacteria, but it also includes viruses, protozoa, fungi, and their collective genetic material which is present in the GI tract. I mean, God must have kept these microbes for something. Obviously, they do some work. They help us metabolize the bile acids. They help us in synthesis of vitamins, lipid absorption, and also in amino acid metabolism. If you look at the interaction between the commensal bacteria, they help in digestion. Also, they have an interaction with the immune system. If your mice is bred in a germ-free atmosphere, the development of immune system is very primitive. The Peyer's patches are very small, the mesenteric lymph nodes are very small in size, and they have a deficient immune system. As you walk down the gut, the diversity of the microorganisms increase, as well as the numbers increase. So actually the colon has the maximum number of bacteria in it, and also has many different types of families of bacteria. A big project was done by NIH to find out that what are the different types of gut flora which is present in humans. So across 3 continents, large number of healthy individuals' gut flora was sequenced, and it was found that we have 3 major enterotypes. One, where the main contributor is Bacteroides. The second, which is dominated by Prevotella. And the third, which is dominated by Ruminococcus. So all of us have our signature enterotype. There are many factors which can affect development of gut microbiome. In early life, the events like the type of delivery, if you get antibiotics in very early life, the kind of food you get, that is, are you breastfed or not, what is your genetics, where do you stay, that actually shapes up our gut flora. This is a very interesting study where the gut microbiome was analyzed every day in one individual for the whole year. And if you see, it is fairly consistent. Only when this person moved abroad, there is a change. But this change comes back to the baseline within a matter of few days. So thus, all of us have a separate enterotype and a kind of gut flora among us. How do you study gut flora? Because most of these organisms are not culturable, so you extract the DNA. Either you can use a stool sample or you can take sample during colonoscopy. So you can either sequence the 16S ribosomal RNA gene, which is different in different bacteria. So once you sequence that, and by using operational taxonomic units, you can find out what are the different OTUs present in that specimen. And you can get an idea which organisms are present. The other way is metagenomics, where you sequence the total DNA. From the total DNA, you can also get the phylogenetic composition. You can also look at minor variations in the microbes, and also you can know what functional groups do these microorganisms have. And we are now moving into the new era, where we also want to look at these microbes. What is their mRNA composition? What kind of proteins do they have? And what kind of metabolome do these microbes have? So that will give us a full handle on the microflora which is present in our gut. So now coming to the topic, that is the gut microbiome and spondyloarthropathy. This is a very excellent review which has appeared this month in Nature's Review, and it shows that 40% of the individuals with spondyloarthropathy have absolutely healthy gut, and 10% of them have inflammatory bowel disease, which will be discussed in the next talk. And another half have some amount of inflammation in their gut, either the colon or the ileum. If you do colonoscopies, or if you look at biomarkers like serum calprotectin or fecal calprotectin, their levels are elevated. The inflammation can vary from acute inflammation to chronic inflammation. And it has also been seen that the chances of gut inflammation are higher in individuals who have a family history of spondyloarthropathy, who are males, and who have elevated CRP. We are all aware of the model of reactive arthritis, where the association with gut microbe is the most strongest. And those individuals show a lymphoproliferative responses to enteric bacteria in the synovial fluid mononuclear cells. They have high IgA antibodies to those bacteria in their synovial fluid, and some individuals have shown presence of bacterial antigen in the synovial tissue also. We always go back to the mouse models because they are more clean and we can understand much better from them. So this is a landmark paper which came in 1994, which showed that HLA-B27 transgenic rats, if they are raised in germ-free environment, they do not develop arthritis, and they also have very low-grade colitis as compared to mice which are raised in the conventional area, suggesting that the gut flora impacts development of arthritis in HLA-B27 transgenic rat. Further, more work led on to help us to know that which are the commensal bacteria which play a role, and it was shown that the Bacteroides vulgaris, if even just monocolonization with this one bacteria can cause development of colitis as well as development of arthritis. That time we didn't understand why Bacteroides vulgaris could cause this, but we now know that Bacteroides vulgaris has mucolytic activities, thus removes the mucus layer from the colonic mucosa, facilitating access of other microbes and causing invasion of the gut epithelium, leading to colitis. What about studies in humans? So this is a study from the French group, from Brebant's group, which has shown clearly that patients with spondyloarthropathy have a different gut flora as compared to healthy individuals. And if you look at the bacteria which was found most often, which had higher abundance, was Rheumococcus navis. And this is showing you the diagram below, that individuals who had spondyloarthropathy along with gut inflammation had the highest carriage of Rheumococcus. And the amount of Rheumococcus in the stool correlated with the disease activity parameters, that is BASTI. I have just summarized the slides from this review, which shows that there are multiple studies. Most of the studies have been done in China and have fair number of individuals with ankylosing spondylitis, but in most of them, different microbes have been found to be increased, different ones have been found to be decreased. So we don't have a consensus that which are the commensal bacteria which are having a signature of ankylosing spondylitis gut microbe. This is a recent paper which has appeared this month in Annals of Rheumatic Disease, where they have done shotgun metagenomics and shown that individuals who had ankylosing spondylitis had similar alpha diversity, but they could be separated out from healthy controls. So the red one is the cases, the blue ones are the controls. And this could be done both in the discovery cohort as well as in the validation cohort. And if you look at the species, the Clostridial species were increased in patients with ankylosing spondylitis, while Bifidobacterium, Lactospiraceae, and Roseburia were reduced in patients with ankylosing spondylitis. And they also studied that what happens when we treat these patients with anti-TNF therapy. With anti-TNF therapy, some of the changes revert back. They come back near normal, like the carriage of Prevotella copri becomes normal. And then they have also done that what happens to the richness of peptides from these microbes, which have a capacity to bind to HLA-B27. So untreated individuals had much more of these HLA-B27 binding peptides containing microbes in their gut. And when they were treated, it came back to nearly the same, not exactly the same as healthy control, but reduced remarkably, suggesting that the therapy can also impact the gut flora. We have also done studies in juvenile spondyloarthropathy, and if you see in this scatter plot again, you can see that the patients segregate separately while the healthy control are all segregated here. And when you look at which are the bacteria which are increased in these individuals, we found that there was increase in Bacteroides, Enterococcus, and Klebsiella in patients with juvenile spondyloarthropathy, while there was reduction in carriage of Prevotella. And there are 3 more studies which have been done in juvenile SPA. Each of them, so rather studies in juvenile SPA have been much more consistent. All of them have shown increased carriage of Bacteroides, and we showed Klebsiella to be increased, while Matthew Stoll's group has shown Akkermansia to be increased, and you have some of the organisms which get depleted. So it's actually a balance of downregulation of certain organisms and enrichment of certain organisms, which defines a dysbiosis. Then we tried to find out that because there is so much of differences, as we saw for ankylosing spondylitis study and for juvenile SPA studies, so we tried to collate our data among the studies from Finland, India, our study, and study from Matthew Stoll. And if you see that each of the country origin actually causes segregation. So the environment impacts your gut flora. So but the patients and controls could also segregate in each country separately. And then we tried to use that if you use training set, that you use the gut flora of different countries and see, can you predict in this validation set? So there was fair amount of correlation, but not perfect correlation. So what does gut dysbiosis actually do? In a healthy gut, we have a very thick mucus layer, so the organisms cannot enter, and we have very tight junctions. So that also prevents the gut bacteria to enter inside the mucosa. But when the gut becomes leaky, because there is dysbiosis, there is gradual depletion of the mucus layer, the gut becomes more and more leaky, the microbes can enter, they can activate the epithelial cells, there is release of danger molecules like MRP-814, which activates the neutrophils and the innate cells, leading on to production of pro-inflammatory cytokines. These produce interleukin-23, and that causes increase in interleukin-17, interleukin-22, and the whole cascade of inflammation. Now there is another concept coming. Does our genetics affect our gut microbiome? And we know HLA-B27 is a major genetic factor in spondyloarthropathy. So this is the data from HLA-B27 transgenic rats, where we see that the B27 transgenic rat has a very different gut flora as compared to wild type. And the 2 organisms which were found much more enriched in B27 transgenic rat was, again, Bacteroides vulgaris and Akkermansia. And this is a very recent study where they have tried to look in 3 different species. So Lewis rat and Fisher rat are the ones who develop spondyloarthropathy, while DA rat does not develop. And again, that it is a genetic background. The gut flora is different in different genetic backgrounds. So this is the Lewis rat, this is a Fisher rat. There are very few organisms which are common. So this is Rheumatology, which was similarly seen in both of them. And again, you see that the wild type and HLA-B27 transgenic rat in each species is also segregating separately. So does the same thing happen in humans? So this study, which came in 2017, actually did not find any difference between B27 negative controls versus B27 healthy controls. So there was no difference in the gut flora between 2 of them. But another study which has come in 2019, they have shown where they have taken samples from the colon, the cecum. They have clearly found that there is a difference between HLA-B27 positive and HLA-B27 negative individuals, that their gut flora is different in different parts of the bowel. So now, once we know that there is dysbiosis in spondyloarthropathy, can we modulate the gut flora? One is diet modification, but there is no clear-cut proof. People have used EEN. It gives some benefit, but how long can you be on EEN? Low sodium diet is supposed to reduce TH17 polarization and probably reduce inflammation. The complex carbohydrates, they can stimulate the growth of short bacteria which produce short chain fatty acid. And we know that short chain fatty acid lead on to basically production of more T regulatory cells. They down modulate the immune response. So if you can get those kind of commensal bacteria, it is good for us. The fecal microbial transplant, not much data in spondyloarthropathy, and there's concern regarding drug-resistant bacteria being transferred. What about probiotics? We did a study in juvenile spondyloarthropathy by using probiotics, which was VSL3. The groups were well matched before therapy was started. But after 3 months of therapy, there was decrease in inflammation in both the groups, but the difference among the probiotic and the placebo group was not different. The placebo group and probiotic group both received non-steroidal anti-inflammatory drugs in addition. We also looked at their other marker, the TH1, TH17, Tregs. Actually, there was no difference between probiotics and placebo, though there was minor changes which happened at 3 months interval. We also looked at the gut flora. Did this use of probiotic change the gut flora? Actually, there was not much difference post-intervention. So is there any data in adult spondyloarthropathy? There is one study which has been done in 147 individuals. The trial was low cost, but demonstrated that on intention to treat analysis, the probiotics did not improve anything. This is a very recent study which is like a prebiotic where you give rifaximin to alter the intestinal microbiota and see. But this has been done in animal and which has shown that we found that rifaximin significantly reduced the severity of ankylosing spondylitis. It downregulated the inflammatory factors. It increased Bacteroides to Firmicutes ratio, and it also increased the lactobacilli. These are all good things. So will the same thing happen in humans by use of rifaximin? We don't know as yet. So thus, ladies and gentlemen, to summarize, we know that gut flora is altered in spondyloarthropathy, but there are no consistent results across studies. There is decrease in diversity of flora in most studies. Bacteroids are increased in some of the studies, and many different species are reduced. We need studies to validate these results in different parts of the world, and probiotics that will restore the altered balance. But it may be different for different countries or different individuals, might help. Should you give directly the metabolite like short chain fatty acid? But that's a problem because these are volatile compounds, have very short half-life and have rapid metabolism, so they cannot be given. So maybe we need to go back to our grandma's recipes, eat good food, have healthy lifestyle, and lead a good life. Thank you.
Okay, that answers most of the questions written by our participants. Most people are wondering, is there any particular diet? That is the answer. And there is a question from Indrajit Agarwal asking about whether there is a difference between adalimumab, etanercept in changing the gut microbiome post-therapeutically.
We don't have data as yet on that. Does adalimumab and or other anti-TNFs alter it differently? Probably it will be coming very soon.
And one more question is there any difference between gut microbiota in rheumatoid arthritis and spondyloarthritis? Is there any?
Yes, there are differences. People have shown some differences, but the problem is that there is so much of heterogeneity even in the same disease. So really, what is truth? We don't know. Because people believe that Prevotella carriage is much more in rheumatoid arthritis. There are other organisms which have been implicated in rheumatoid arthritis, but there also the results are not consistent.
Okay, there is a thing. Last question. My question is going to be the last question. Chairman's privilege. And there is a gender difference between men and women in gut microbiota. Estrogen and androgen are supposed to influence the microbiota. Has that been investigated as a potential reason why men have a higher incidence of spondyloarthritis?
That has not been as yet done in spondyloarthropathy areas to look at angst individuals who are being females versus males. So that data is not, that's a very interesting question and it is worth looking at it. So do women have a less severe disease? We used to believe that, but now we are gradually coming down that actually the prevalence is similar. If you look at non-radiographic SPA, there is no difference. So it is just that the males have a much more severe disease. So they present much more with ankylosing spondylitis. Otherwise, spondyloarthropathy is no different between females and males. So would the gut flora play a role in severity of disease? So that data needs to be generated.
I think we have one more minute for question answer session.
Okay.
And Dr. Damodaram is wondering, is there any markers to look for leaky gut?
Yeah, there are markers for looking at leaky gut. So one is fecal calprotectin, which is a marker for subclinical inflammation. Otherwise, people can label BSA and they used to do studies, radionuclide studies to see if there's a gut leakiness. But the easiest way is to just look at fecal calprotectin.
Okay. And I think one more minute, you have answered wonderfully. And is there any role of vitamin D in changing the gut bacteria?
I haven't looked up that. I haven't looked up that, so I won't be able to answer at this time.
Thank you very much, Dr. Amita, for this wonderful talk and clarifying many of our doubts. Now we will move on to the next topic. Next topic is again on the same line, the gut feeling, enteropathic related arthritis. And our speaker is going to be Dr. Varun Dhir. He is an additional professor of medicine and rheumatology in PGI Chandigarh, and he's a very bright rheumatologist and an excellent speaker. Over to you, Dr. Varun.
Yeah, good evening. Thank you, Dr. Dharmanan, for that kind introduction. And I'll just start screen sharing now. Yeah, so the topic given to me is enteropathic arthritis. And I'll start off with a case vignette. And this was a young boy when he started having the disease. He started with classical inflammatory back pain, groin pain at when he was around 12 years of age. That was in 2012. He's a millennial. He was born in 2000. So, and it took him 2 years to reach to consult and get a diagnosis of spondyloarthritis. And in 2014, he was investigated and found to MRI confirmed bilateral sacroiliitis. He was HLA-B27 positive. At that time, apart from his axial symptoms, he also had knee arthritis, which was swollen, and it was injected with steroids. He was started on, in view of peripheral arthritis as well as early axial arthritis, he was started on sulfasalazine along with the NSAID, and which he took for around 3 to 4 months without much benefit. And he opted to start to go on to anti-TNFs. And he was given just 1 dose of infliximab in 2014, and with which he went into remission for 4 months, subsequent to which he came back with some symptoms again coming. He was at that time put on sulfasalazine with the toricoxib, and he did reasonably okay for around 2 years, in which he was symptomatic on and off, but he could carry on. He came back in 2019 with severe low back pain, groin pain. He was limping. He couldn't walk. In fact, he came in a wheelchair. He was given etanercept for around 12 weeks, with which he did not have any benefit. Shifted to adalimumab, which was again given for a period of around 12 weeks, subsequent to which he developed a adverse effect in the form of persistent cough. And although he was investigated with the chest X-ray, he was not febrile. Adalimumab was stopped, and also he didn't have much improvement with that. Subsequent to that, he continued on non-steroidal anti-inflammatories, but he developed anterior uveitis. He developed increasing peripheral arthritis in the form of ankle joint as well as knee joint involvement. And this was his condition when he came to us. And so at this point of time, a CT chest abdomen was done, which did reveal colonic thickening. Actually, a CT chest abdomen was done because some of his joints were, he had some history of weight loss and some of his joints showed redness. It was thought that could he be having some kind of a Poinset's kind of an arthritis, and it revealed colonic thickening in the descending colon. A stool calprotectin was raised. It was around 800 micrograms per gram. The usual cutoff in our institute is around 43, although many places consider 250 as a cutoff. And a lower GUI endoscopy was done by the gastroenterologist, which revealed multiple ulcers, the biopsy of which showed non-specific inflammation. And so with this diagnosis of inflammatory bowel disease associated arthritis, probably indeterminate colitis, juvenile onset, both axial and peripheral arthritis, HLA-B27 positive with uveitis in the past was made. And this is just to show you that he was subsequently started on infliximab, because in 2014, that was the one drug that had led to a long-term remission of almost 4 months. And he was started on infliximab. And you can see in this graph here, his acute phase reactants, when he came to us, it was pretty high. His CRP in the red, going almost till 120 milligram per liter. And if you can see here, the blue line, which is showing his erythrocyte sedimentation rate, again rising, and he was started on infliximab, which led to some response, but he had a secondary non-response with a rise in his CRP and ESR. And at this point, we did get anti-infliximab antibodies done, which was strongly positive. So I'll come back to this case later. So what exactly is enteropathic arthritis? Now, the best definition I could come up with is a disease in which there is concurrent inflammation of the gut, which is overt, and joints. Why I say overt is obviously that we are well aware and that subclinical gut inflammation can be there in a variety of, in many patients with spondyloarthritis. And do we call them enteropathic arthritis? Obviously not. So it's obviously overt gut inflammation, whether that's diagnosed endoscopically or by some form of imaging, or the patient is symptomatic. And obviously arthritis, or which could be peripheral axial. And so obviously the prototype of this would be inflammatory bowel disease, namely ulcerative colitis and Crohn's disease. But you also have a variety of other diseases which present with gut symptoms and joint symptoms. Whipple's disease, which is obviously an internist, something the internists like to keep as a possibility for explaining multi-system involvement. Celiac disease, which would be which is supposed to be common in the wheat belt of our country and probably underdiagnosed. Bacterial overgrowth arthritis, which is probably something which I'll discuss these later. Behçet's, which can present with arthritis and gut symptoms. Microscopic colitis. And I put enteric reactive arthritis in brackets because that's not typically considered to be actually an enteropathic arthritis, but we know that it can be very difficult to differentiate once the patient often has ongoing bowel symptoms along with arthritis. So coming to IBD-associated arthritis, which is the prototype in this sense for enteropathic arthritis. And if you look at ulcerative colitis and Crohn's disease and indeterminate colitis, UC and CD are around 1 in 1,000, a prevalence of 1 in 1,000, similar to lupus, if you look at it. And obviously there is a variation much more in the Western hemisphere than in the East. But we know that it is being, whether it was just a matter of not being diagnosed is difficult to say. And what is important in these inflammatory bowel diseases is the extraintestinal manifestations. And we all know that what are the extraintestinal manifestations? We're going to concentrate on the joints, which can obviously, as we all know, have a axial involvement or peripheral arthritis. And obviously, this being a spondyloarthritis, one of the forms of spondyloarthritis, you do get dactylitis, enthesitis in some proportion of patients. So I'm just going to spend one slide on pathogenesis. And so there are two schools of thought. One school of thought thinks that probably the gut is the primary place where all the problems take place and the arthritis is secondary. Now, this has been shown to some extent that there is increased gut permeability in many of these patients of IBD, as well as even in patients who don't have IBD but have spondyloarthritis. There is an increase, this leads to an increased antigenic load and immune activation. Circulating immune complexes have been shown to be increased in some studies, say against bacteria like Klebsiella. And you've shown, people have shown that mucosal invariant T cells are present in the synovial fluid. These cells are usually present in the gut. So they're being present in the synovial fluid suggests that some kind of an immune response starts in the gut and goes to the joints. There's another school of thought that does think that they could be part of the same process, and that is what's what you call probably we are veering to in terms of a common genetic or environmental trigger. The fact that we get a lot of subclinical intestinal involvement in spondyloarthritis does suggest again that they're actually part of the same disease. And animal model data, again, suggesting that a lot of these HLA transgenic rats, which Dr. Amita spoke about, also shows that there is concurrent gut and joint involvement. So it suggests that it could be that they're both part of the same process because of an environmental trigger or genetic trigger. There's an immune activation which takes place, and the result of which is joints and gut getting involved. Now, important to us is how common is arthritis and inflammatory bowel disease. So this is a figure from a systematic review, a forest plot from a systematic review published in 2017. And this is the picture you see is showing you the prevalence of sacroiliitis. And obviously, as we would appreciate, that it depends a lot on, if you look at the top, it depends a lot on whether you diagnose sacroiliitis based on a clinical evaluation, whether this is a prospective study, a retrospective study based on case reports, whether it's self-reported. So if you look at these numbers, which you to the left of this line, these are the number of studies. So 28, 21 studies, 7 studies looked at self-reported sacroiliitis, and you can see that there's a wide variation. And if you look at the x-axis, this basically shows you the percentage. So 0.05 is 5%, 0.1 is 10%, 0.15 is 15. And you can see that the dotted, the dashed line is hitting around 0.1, which is 10%. So that is the average they could get across all these studies done by a variety of methods. I'll come to the other parts a little later. And, but I'll go on to a prevalence of peripheral arthritis, which was again part of the systematic review. And they again found a variety of studies by a variety of outcomes, looking at clinical evaluation, case reports, self-reported. And they found, if you can look at the central line, the dashed line, which is hitting the x-axis around 0.15. So it was around 13 to 15% was the average of taking all these studies together. They had around 70 studies which were part of this meta-analysis. So I'll just like to draw your attention to important parts where these red rectangles come, which is that in both peripheral and axial arthritis, Crohn's disease has a much higher prevalence than ulcerative colitis. And you can see this across both of these in the red rectangles. And another thing which I like to point out again below this red box in the prevalence of sacroiliitis is the type of sacroiliitis. And if you can look here, that subclinical sacroiliitis is actually higher than clinical. This is worth remembering because it has been reported in this disease that there are a lot of patients with subclinical sacroiliitis, and when you do an X-ray or an MRI, you can find sacroiliitis in a large number of patients. And there's studies from the 1990s showing up to 50% of patients with IBD might have changes of sacroiliitis on X-rays. And there are also studies with MRI which have shown that subclinical, that is patients without symptoms, without back pain, also may have, IBD patients may have sacroiliitis. And so just emphasizing that sacroiliitis or axial disease is less common than peripheral arthritis. And there are around 10% and 13 to 15% of patients with inflammatory bowel disease will have these as an extraintestinal manifestations. So I think the important question is that when do you suspect IBD in a spondyloarthritis patient? That's how we would look at these patients. They would come to us with spondyloarthritis, obviously. And obviously, we are all aware that if you get frank blood and stools, a history of iron deficiency anemia, you get weight loss, you get features of Crohn's disease like anal fistulas, a family history of inflammatory bowel disease. These would be typically the things we would be looking for. But something which is also equally important to consider, it's a very soft point, would be that inflammatory bowel disease in spondyloarthritis would be more likely in a patient who's actually B27 negative and a patient who's having significant peripheral arthritis without obviously having an obvious cause like a psoriatic arthritis. So this would be something you would consider, just at the back of your mind, a soft point. a patient of spondyloarthritis with a very high CRP without an obvious cause could be another soft pointer towards having an underlying IBD. And this is actually what happened in our index case as well. And the third soft point would be extensive sacroiliitis on MRI, where you're getting a lot of edema on the MRI, but the patient is not that symptomatic. This has been also reported to be a soft point that's towards that these patients could be actually IBD-associated spondyloarthritis rather than just spondyloarthritis or undifferentiated or angst-spond per se. Now, let's look at the other way. If you're looking at IBD patients, which are the patients you would think are more likely? And people have looked at these by various studies, and they found that it's not there's no gender ratio. It can occur at any age, but there's an increased risk, as I said, of Crohn's patients with Crohn's disease rather than more than ulcerative colitis to develop arthritis, and increase on colonic involvement. So if you have colonic involvement, that's the large bowel involvement, more chances of developing arthritis. Increased risk if you have other extraintestinal manifestations. So a patient like say with erythema nodosum, a patient with uveitis, a patient with perianal disease, a patient with would be more likely to develop spondyloarthritis or peripheral arthritis. And it's important to remember, obviously, what we are concerned about is many of these patients could be having subclinical or who have not developed IBD and may develop IBD later on. And that can obviously occur in these patients. So let's get down to the types of IBD-associated arthritis. So as I said, let's start with the less common one, which is axial. And now importantly, just like psoriatic and reactive arthritis, axial spondyloarthritis associated with IBD has much less HLA-B27 positivity than we get in ankylosing spondylitis. So it's just around 50 to 70% compared to around 90% with angst-spond. And the axial arthritis or spondyloarthritis phenotype is independent of IBD activity. So it doesn't need to go with the flares of, if you're having a flare of ulcerative colitis, that the axial disease increases. That's not been found. And it may precede IBD, and typical angst-spond can result. So is nothing to think that this would be milder. So patients can have chest restrictions, stoop posture, syndesmophytes, that can all be the same and just mimic angst-spond. And the second, let's talk about the more common, which is the peripheral arthritis. And if you, the type, it was divided, a large study found that you can divide it into two parts. Most of us, it's important to be aware of this because there is some differences in them. So the type 1 is something which I think of akin to a reactive arthritis. So it's more intermittent, it's milder, it's associated with the bowel activity, and it's associated with HLA-B27 as well as HLA-DR1. And if you look at type 2, which is polyarticular, so more than five or more joints involved, and this is typically just like RA. And so I remember it by just thinking it's similar to RA. So it's more persistent, it's more severe, it's more chronic. Typically, although the peripheral arthritis of IBD has been reported to be non-erosive, but this form can develop erosions, obviously because it's persistent. And this form is not correlated with bowel activity. And here the HLA association is HLA-B44 and not HLA-B27. How much this helps clinically obviously would be limited, but it's worth being aware of this. And just going on and, talking about differential diagnosis or other enteropathic arthritis. And here we have celiac disease, typically uncommon patients you see with it, and typically we don't screen with them, and probably it's supposed to be relatively mild and responds to a gluten-free diet. It's again non-erosive arthritis. It can be oligo or poly. Whipple's disease, which is typically you would consider a patient who's presented with malabsorption, weight loss, CNS. It's typically said to be migratory arthralgias. Enteric reactive arthritis, obviously we know, is sometimes of a big confusion because gut symptoms are typically said to precede arthritis by 2 or 3 weeks, but we know that gut symptoms can go on in a large number of patients, and the patient might present with concurrent gut and arthritis as well. In a lot of our patients, we see that despite them, and typically, obviously, the stool cultures and the history would be important, which although serology has been said that looking at serology for Shigella or something could be helpful, but we hardly do that. And again, Behçet's disease could be an important manifest, could present with gut and joints as well. And the gut can be, there could be mucosal ulceration of the small bowel and could just mimic Crohn's disease. And basically you would think of, if historically you have a patient who has an eye involvement, significant uveitis, typically maybe bilateral uveitis, posterior uveitis, or prominent, genital ulcers, oral ulcers, and obviously we would think of that. Just covering, one would be intestinal bypass would be somewhat of a, it was a weight loss procedure in the past where they, bypassed a part of the small intestine, and that became a blind loop, and that led to bacterial overgrowth, which could present with skin manifestation as well as joints. And that was known as the intestinal bypass arthritis, used to respond to antibiotics. And one important thing which we might see more and more is microscopic colitis. And this is supposed to be, in which endoscopy will be absolutely normal, but it's on the biopsy that you'll find some changes, whether of collagenous colitis or microscope or lymphocytic colitis, and where it's often due to drugs that the patient is taking, a variety of drugs, and it could be associated with a lot of autoimmune diseases, and which could present arthritis as well. Now, coming to the treatment of inflammatory bowel disease associated arthritis, I think it's important that we look at the conventional treatment first. And if we look at the conventional treatment, non-steroidal anti-inflammatory drugs are controversial, obviously. But when I looked in this recent review, and there have been small randomized controlled trials using COX-2 inhibitors, celecoxib and torcoxib. But they were not found to exacerbate IBD symptoms, but they were obviously very short trials, just 2 weeks and 3 months. There was one trial with rofecoxib, the molecule which was withdrawn because of cardiovascular side effects, which found around 20% flare of IBD. So there is a risk that it might flare IBD, but it's something which has been recommended to be still used because it's so effective. The second, obviously, short course steroids, which are used in inflammatory bowel disease flares as well. They also use methylprednisolone pulses, the gastroenterologist as well, for IBD flares. And we can use oral steroids as well as a short course, obviously. And obviously, local injections of steroids into peripheral arthritis is something we commonly do. Conventional immunosuppressants which have been used, which find both a benefit of the gut and the joints, are sulfasalazine and methotrexate. These are the ones we are most comfortable with and best known. Azathioprine and cyclosporin or tacrolimus theoretically are actually used again, both by gastroenterologists for IBD as well as rheumatologists for sometimes arthritis. We know that azathioprine, although we don't use it commonly for arthritis, does have an good anti-arthritic efficacy, as well as tacrolimus, although we don't use it for arthritis so much. But it's not clear what would be their role, especially with biologics and JAK inhibiting it. And of course, there's no data to say about whether leflunomide or mycophenolate mofetil among the conventional would be effective in this kind of scenario. Now, this is which I've taken from the review in Gut, which has come in 2020. And you can look here on the top. This is just showing you a big green rectangle below anti-TNFs. And you can see IFX would be infliximab, adalimumab, satralizumab, and golimumab. And you can see the top, panel is peripheral arthritis, and the small, the below it is axial arthritis. And you can see it's green in both, suggesting that, that anti-TNFs have great efficacy in both peripheral and spondyloarthritis. And we know that it's true in IBD-associated arthritis as well. The second would be ustekinumab, which is again has shown efficacy in IBD, and it would show, it has been, although we don't have much data with it, but it's supposed to be again green for the peripheral arthritis. It would help the peripheral arthritis, but not the axial arthritis. What about JAK inhibitors? So tofacitinib, we know that tofacitinib is well used in peripheral arthritis, and from that, and from some anecdotal reports in IBD-associated arthritis, it's thought that it would work well. That's why it's a green for peripheral arthritis of IBD, and it's a yellow for the axial arthritis, because we know that, again, tofacitinib, although not approved for axial arthritis like angspon, has been shown to be beneficial in a phase 2 study, which was published in 2017 in spondyloarthritis. And again, they're just anecdotal reports in IBD-associated, so it's given a yellow. And anti-integrins, vedolizumab, something which we are not so much aware of, but it might have a benefit in arthritis as well as a yellow, might have a benefit. So yellow is might have, green definitely indicated. So if you can look at the greens, it is basically for anti-TNF for every kind of arthritis, JAK inhibitors for also both kinds of arthritis, and ustekinumab only for peripheral. Now, importantly, just important to say here, etanercept is not indicated, not so much because of it can cause flares, but because it doesn't actually help the bowel. So, or it might help the arthritis, this review said that you might try it in a patient you're desperate, you don't have any other drug, and the gut is stable. But generally, it's not used because you want a drug which affects both the bowel and the arthritis, and etanercept doesn't do that. Anti-ILs. Yeah, okay. I'm just about to, I think I've overshot my time, and this is just around my second last slide. Anti-IL-17, I'll just take a minute and just show you that anti-IL-17, obviously, for IBD is a big no-no, because there were 2 phase 2 studies, both of which showed that actually the gut can flare up by using anti-IL-17. So they're not given in IBD per se. They lead to much more flares. Generally, you don't get this kind of a picture, which is like you're getting a severe enough gut involvement to cause, surgery being required and colectomy, but you can get that. So generally not used in any patient with IBD or suspected IBD. And, but let's look at the other way. If you use it in angstpond or SPA, what's the risk of getting an IBD? That is flaring a subclinical IBD. It seems to be very less. Among around almost 17,000 patients in this systematic review, they found only 12 new cases of IBD developed. So the risk, if at all, when we are using things like secukinumab, which is available in our country, would be very low. Finally, to go back to the clinical case vignette, we looked at this patient who had already received anti-TNFs and actually started him on tofacitinib. And he did better with this, this patient of juvenile IBD-associated spond and peripheral arthritis did better, but we're still keeping our fingers crossed. This is something which can be considered when the anti-TNFs have failed, but obviously the first would be anti-TNFs. Finally, to conclude, this is my concluding slide, that enteropathic arthritis just means that you have overt gut, whether endoscopic, clinical, or imaging involvement of the gut plus arthritis, and the prototype would be IBD-associated. Typically, you find in IBD spondyloarthritis or axial. What I mean is axial arthritis in 10%, peripheral arthritis 50%. And these are the types. So that would be all for this presentation. And I'd like to hand back to the chairperson, please.
Thank you, Dr. Dil. Wonderful talk. And we have, I think, enough time for a couple of questions. Rajan Kumar wondered whether we should do calprotectin in all patients with spondyloarthritis to detect occult IBD.
Yeah, that's an excellent question. And I can start by saying that this review, which has appeared in Gut in 2020, just last month, suggested, yes, that you could do it and take a cutoff of 250. But I was thinking about it, with the kind of, I showed you that data, which was of 17,000 patients, and the risk is just around, they could just get 12 cases. Obviously, there is a reporting bias, but it doesn't seem to be that common that you're going to, and in our country, we'll have to balance it because we'll be adding one more test apart from the already the patients have a long list of tests before they're starting, and we'll have to look at it. But it has been recommended, at least by this author, that you might use a cutoff of 250 and then only go for secukinumab.
And another question from Dr. Gupta: how common is asymptomatic IBD in HLA-B27 positive ankylosing spondylitis?
Okay, so I removed, there was one slide which I've removed. So depends on the way you look at it. There have been studies which have looked at biopsies and said that, yes, microscopic involvement is there in 50%. But if you look at overt, that is endoscopic studies, they usually find it in 5 to 10% of patients who are not symptomatic. Obviously, we are talking about patients who are not symptomatic for IBD and who've been evaluated. So microscopically, you might get a much larger involvement. Now, whether that involvement is true IBD or whether it's the effect of the NSAIDs these patients have or some other effect is very difficult to say. So there would be studies which would say up to 50%, but those are, just remember, microscopic on biopsies, and there would be studies which would say overt just in 5 to 10%.
Thank you, Dr. Varundir. And I request you to go through the Q&A session, and you could probably type in the answers for the guys who didn't get the answer, put a chance to answer, ask the questions. And I hand over the podium to my co-moderator, Professor Ashok Kumar.
Thank you, Dr. Dharmanan. It was a wonderful session. Now, the next talk is on uveitis in the spondyloarthritis spectrum. And the speaker is none other than Dr. Ramesh Joyce from Bangalore, who is so well known for his great oratory skills. and even better for his debating skills, I must say. I have attended many of his debates, which were very, very interesting. So he's going to speak. He's an astute clinician. From whatever interactions I have had, I would, without much ado, request him to get started because we have some shortage of time.
Thank you, sir. I'll just share my screen. So thank you very much. It's wonderful getting back to the IRACON, albeit in a different manner. So my topic that I'm going to cover in the next 20 minutes is about uveitis. And I think I should thank my ophthalmology colleagues in Bangalore and the Uveitis Society of Bangalore, which is a very proactive group, who have actually formulated my thoughts in looking into the eye in patients with rheumatic diseases. So I work in close tandem with a lot of ophthalmologists in Bangalore, and we have a very good group. So the standardization of uveitis nomenclature criteria, or the SUN working group, classifies the eye into 3 compartments for ease of understanding. And when the anterior chamber is affected, it's called anterior uveitis, something that happens in front of the lens. When the inflammation spills over to the anterior part of the vitreous, it's called intermediate uveitis or pars planitis. And then when the choroid and retina are affected, it's called posterior uveitis. And when all the 3 layers are affected, it's called panuveitis. So through my talk, I'll be going through these nomenclatures quite frequently. So when it comes to the spondyloarthritis, generally uveitis and spondyloarthritis is unilateral. It starts off all of a sudden. Patient comes with photophobia, redness, sometimes with blurred vision and painful eye, and it could be unilateral or unilateral alternating, or sometimes recurrent, and majority of the times it's anterior uveitis. And generally the uveitis, when you ask the ophthalmologist, they'll specify that it is non-granulomatous. It's very important to differentiate non-granulomatous versus granulomatous, because predominantly granulomatous uveitis is seen in tuberculosis and sarcoidosis. And I'll show you a few slides of uveitis as to how it looks. So, and intraocular pressure is usually low due to severe inflammation of the body, but very rarely you can get panuveitis or posterior involvement. However, choroiditis and retinitis is not a feature in spondyloarthritis, so you have to think of another diagnosis if you see it. But generally, the posterior segment involvement could be in the form of a hyperemic disc, macular edema, or perivascular leak on a fluorescein angiogram. So this is the few cases that I'm going to show you are my patients that I have been looking after with the ophthalmologist. And this is a classical example of non-granulomatous anterior uveitis in a HLA-B27 positive individual. And on slit lamp examination, what you see here, as I've pointed out in the arrow, is fine keratic precipitates in the anterior chamber and circumciliary congestion. And when the inflammation is very dense, you could form a precipitate like this called hypopyon in the anterior chamber, which looks like this on a slit lamp. And intermediate uveitis, when the inflammation spills into the anterior part of the vitreous, you have a hazy anterior complex. And then on slit lamp examination, this is the anterior vitreous, which shows inflammatory cells or deposits. So I should thank my colleague, Dr. Padmamalini from Narayan Netralaya, for loaning me these slides. Very rarely, HLA-B27 related individuals can have posterior uveitis. When you have very bad vitritis or posterior vitrea being involved, you can, on clinical examination, you could see a hazy vitreous, a hazy fundus like this, and that's because of an inflamed vitreous. And if the inflammation is very severe, you could see a dense condensation like what I've shown here, and a bit of subacute inflammation persisting can form fibrinous deposits, and this is called fibrinous anterior uveitis. And this has been, a slide has been loaned to me by my other colleague, Dr. Kalpana Murthy, and thanks to her. So If these patients do have posterior segment inflammation, as shown in this particular patient, you can see fibrinous deposits here, and then you can see a cystoid macular edema here. And if you do an optical coherence tomography or OCT, you could see a subretinal fluid pocket as shown here. And this is a classical cystoid macular edema that can be seen in panuveitis. And that was our patient with good response post-treatment. Very rarely, you can see this presentation, which is a hemorrhagic hypopion in a B27 positive individuals. So it's important to recognize uveitis at an early stage, because if these episodes are recurrent, if they are chronic, if they're suboptimally treated, the consequences could increase the ocular morbidity. And one of the most important complications is posterior synechiae, where the posterior surface of the iris gets stuck to the anterior surface of the lens, causing a shapeless pupil and also increasing the chances of glaucoma. Frequent inflammation plus use of topical corticosteroids could result in premature cataracts and corneal decompensation. Recurrent inflammation could cause ocular hypotony or phthisis, and rarely posterior segment inflammation could cause cystoid macular edema, epiretinal membranes, which is an inflammatory membrane right in front of the retina. And we should not forget that uveitis accounts for 10% of all causes of blindness. Doesn't necessarily have to be only B27 induced, but uveitis in general. So coming specifically to uveitis and spondyloarthritis, the first report was from England by Brereton in 1973, who described the first association between HLA-B27 and acute anterior uveitis. And in his cohort, he described that 52% of patients with anterior uveitis were B27 positive compared to only 4% amongst controls. So since then, variety of cohorts have looked at the prevalence of uveitis in SPA, or the other way around, the prevalence of SPA in uveitis. And if you look at the prevalence of anterior uveitis in SPA, it's roughly about 32%. However, it forms the most common extraarticular manifestation, affecting nearly more than 20% of SPA patients. Sentinel study was a large study from Spain, and it analyzed data of patients who presented with acute uveitis to the emergency ocular eye departments, and 475 subjects were looked at with B27 associated anterior uveitis and were screened for arthritis, and it was shown that 70% had axial and 22% had peripheral arthritis. Another pivotal paper from Haroon et al. Came from Dublin, and this was called the Duet study, which also looked at the same thing, and it was shown that about 40% of patients presenting with idiopathic anterior uveitis had undiagnosed SPA. And these were from the era where MRI was not used. There was a recent published small series of patients with MRI as a diagnostic tool. It was shown that 23% of patients had SPA. So the bottom line from all these literature would mean that in those patients with uveitis, always do not forget to ask for history of inflammatory back pain, and do not forget to look for peripheral SPA manifestations. And this has to be told to your ophthalmology colleagues. Now, if you look at the prevalence of uveitis in these diseases, it is lower in the spectrum of spondyloarthritis. It's lower in patients with undifferentiated SPA and much higher in those with frank ankylosing spondylitis. And the prevalence increases with disease duration. What about non-radiographic SPA? This is an important entity which has been recognized of late to be more important. And a systematic literature review looked at the various extraarticular manifestations to see whether non-radiographic SPA and angstpond, the classical angstpond, was similar. And this review showed that peripheral arthritis and other extraarticular manifestations were equally prevalent in both. Whereas when it came to uveitis, the uveitis was more prevalent in classical AS compared to non-radiographic SPA, which also says that disease duration might play a role. IBD and psoriatic arthritis patients, the likelihood of uveitis is far lesser than what you see in AS. But of the patients with IBD or PSA, at least 50% who have uveitis, at least 50% of them are B27 positive. But the phenotype of the uveitis might be different in that these patients might have the more severe manifestations of interior or intermediate or posterior involvement, or also bilateral uveitis, which is unusual in spondyloarthropathy. The pathogenesis parts of it has been covered in various presentations today, but there's some interesting observations that we need to look at. HLA-B27 association is widely known, but however, when you look at the cohort of HLA-B27 negative anterior uveitis, the prevalence of SPA in the Spanish cohort was close to 19.5%. When HLA-B27 transgenic rats, which develop spontaneous inflammatory diseases in the vertebrae, skin, and nails were seen, the uveitis was infrequent, suggesting that maybe it's just not about HLA-B27. You need something more to cause uveitis. And then other than HLA uveitis, HLA-B27, major histocompatibility complex loci like IL-23 receptor, ERAP1 and others have shown significant association between uveitis and SPA. Amita madam has extensively covered the role of infection in perpetuating inflammatory diseases. And one of the earliest models was transgenic rats infected with Salmonella and Yersinia, which in turn precipitated uveitis. So gut microbiota also have a role because they activate certain T cells that are oculotoxic. And finally, most recently, there have been some genes that have been described which affect an individual's susceptibility only to uveitis, but not to spondyloarthritis. And these are IL-18R and IL-10. So when a patient with acute anterior uveitis is seen in the ophthalmology department, what should the ophthalmologist do? My request to all my colleagues would be, give them one of these algorithms. The ASAS has come up with a simpler version. All they have to do is to ask one question about chronic back pain in an individual who's less than 45 years age, lasting for more than 3 months. If he does have it, refer the patient to a rheumatologist. The Dublin algorithm had a couple of other extra things about doing a HLA-B27, positives being referred, negatives look for history of psoriasis and being referred. So whichever is the referral pattern, the Duet algorithm, because of its other factors, had a higher sensitivity, specificity, and positive likelihood ratio. The goal of treatment is suppression of inflammation. You have to control inflammation in the eyes. And when it means control, the oral steroid intake has to be less, and topical steroid should be less than 2 drops into each eye per day. And complete remission would be no ocular inflammation and not needing steroids. Although majority of anterior uveitis resolve with simple topical treatment, it's important to understand that 15 to 20% of patients with ocular inflammation may be chronic and could be more severe. The treatment, typically when they go to the ophthalmologist, they get is topical steroids and cycloplegics to prevent posterior synechiae. In very severe disease or where their vision is very badly affected, a short course of oral corticosteroids, or where deemed appropriate, locally injected corticosteroids, either periocular or intraocular, is considered by ophthalmologists. And this is one of my patients managed by Dr. Padma Malini. Just to give you an example, that this patient had vision dropping down to finger counting at baseline with topical and oral steroids. In a few months' time, he had 6/6 vision. So when the question comes, who should be started on steroid-sparing agents, what is the criteria? The Ocular Immunology and Uveitis Foundation came, especially when it comes to B27-related uveitis, to say that those with recurrent refractory iridocyclitis, intermediate uveitis, or panuveitis should definitely start steroid-sparing drugs. And what is recurrent? Nobody has a definition, but for arbitrary reasons, we consider, along with our ophthalmologists, at least more than 3 attacks per year. A group of experts formed an initiative called as the Focus Initiative, who elaborated on what would be the ideal candidate to receive DMARDs upfront. And when you look at the anatomic reasons, it could be sight-threatening acute disease, chronic persistent inflammation, exudative retinal detachment, posterior involvement, and binocular sight-threatening disease, although this is unusual in spondyloarthritis. If the visual acuity is very bad, if the vitreous haze is of a higher degree, relapse of cystoid macular edema, and failure of topical or periocular steroids, and anterior uveitis occurring while the patient is on prednisolone, or while tapering prednisolone, or for some reason you cannot give steroids or the side effects are unreasonable, so then you will have to initiate them upfront. So when it comes to that question, which drug, it's $1 million question, because the data was very sparse for a long time. Sulfasalazine had only 2 studies and the numbers were very small. I'll talk about methotrexate and MMF in a minute, whereas there is no data for cyclosporin, tacrolimus, azathioprine, or cyclophosphamide. None of these have a data in anterior uveitis of spondyloarthritis origin. The important trial to say which is superior, whether methotrexate or MMF, although Mount Sinai and other trials from the US said MMF had a marginal benefit, Professor Rathinam from Madurai Institute of Ophthalmology, Arvind Institute, and others in a multi-center trial compared methotrexate 25 milligrams weekly with mycophenolate 3 grams, and ocular parameters were no superior, improvement was no superior in MMF compared with methotrexate. So both drugs could be used, and methotrexate would be a reasonable first choice drug for those with resistant uveitis. However, one important advice you have to give the ophthalmologist, what I have seen in actual clinical practice is the moment we start patients on DMARDs, the ophthalmologists assume their job is done and they stop the steroids. We have to make it a point to them that our DMARDs are slow to work. There should be a steroid overlap. Do not stop steroids, whether it's topical or oral, till immunosuppressives work. Sometimes 1 or 2 drops of topical steroid has to be continued for 4 to 6 months till the patient stabilizes. Finally, the role of biologics. The TNF, as we know, is an important mediator of inflammation in spondyloarthritis, and high levels are found in serum, skin, and joints. And in the early 90s, intravitreal injection of TNF-alpha induced inflammation in rat eyes, and elevated levels of TNF-alpha has been seen in serum and aqueous humor in uveitis patients, and concentration of TNF-alpha in aqueous humor of HLA-B27 positive patients is definitely higher compared to negatives. So whether biologics worked in uveitis, the initial data came from analysis of the pivotal spondyloarthritis trials and large retrospective series, and was shown that infliximab and adalimumab reduced the frequency of acute anterior uveitis. This also came from real-life experience like the Swedish biologics registry, which duplicated this data. Another large open-label prospective study called the Rhapsody trial, which had 1,000-odd patients, suggested that adalimumab reduced the rate of anterior uveitis flares by more than 50%. However, 3 pivotal trials were published in the last 5 years, and they were called the Visual 1, 2, and 3. Visual 1 was a multinational phase 3 trial comparing adalimumab with steroids in acute non-infectious intermediate, posterior, and panuveitis. Just please note that this is not for anterior uveitis. However, we have been extrapolating this data for even anterior uveitis. I was shown that the primary endpoint of visual improvement or time to relapse was significantly lower in adalimumab compared to steroids, and all the secondary outcome measures like the vitreous haze, new lesions, anterior chamber cells, and worsening of visual acuity favored adalimumab compared to steroids. And maintaining immunosuppression is very important to control inflammation, as shown by the Visual 2 trial. And this showed that maintaining adalimumab significantly lowered the risk of uveitis flares. And Visual 3 was also published, which was an open label confirming this finding. So based on all these trials, adalimumab became the only non-steroidal agent approved by the US FDA and the EMEA for intermediate, posterior, and pan-uveitis. And this is another clinical example of one of our patients managed with Dr. Padma Malini showing significant posterior uveitis. And you can see the cystic spaces in the subretinal space resolving with adalimumab. Finally, is there a role for other biologics in uveitis? Other TNF agents like golimumab have very small case series published. Most of it is derived from the clinical trials. Abatacept, some partial benefit in GIA-associated uveitis and psoriatic uveitis. And tocilizumab has been used in GIA children with very resistant cystoid macular edema, and rituximab very rarely, but not of great benefit in spondyloarthritis. Which brings us to the last part of my discussion. One is the association of etanercept and uveitis. Braun's pivotal paper in the early decade showed that there was a reduction, greater reduction in flares with infliximab compared to etanercept when these drugs were used in ankylosing spondylitis. And Galler's trial, particularly targeting uveitis, showed that compared to etanercept, infliximab for treating inflammatory eye diseases showed a greater efficacy, and the risk of recurrences was almost zero in infliximab treated patients, whereas it went up to as high as 60% in etanercept treated patients. A retrospective analysis of US claims database of 2,000 odd AS patients showed that the higher risk of developing new onset uveitis in patients with AS treated with etanercept was higher compared with those with adalimumab. And my last two slides. The secukinumab is not as simple as etanercept. Now, it has been recognized that IL-17 T cell levels are elevated in blood in those with HLA-B27 associated anterior uveitis. IL-17 blockage has resulted in a dramatic reduction in the leukocytes in aqueous humor and vitreous in mice, as well as helping with peripheral arthritis. So technically speaking, secukinumab should have worked for uveitis. So secukinumab was tested in 3 RCTs for uveitis particularly, and it was shown that it did not achieve the primary efficacy endpoints. However, an important point to note from these trials is these trials were not specifically SPA-related uveitis. Finally, there is a more recent publication from Professor Atul Deodhar, which was an amalgamation of data from measure 1, 2, and 3 clinical trials of secukinumab in ankylosing spondylitis and the post-marketing safety analysis. And the conclusion was that secukinumab, from the analysis of these trials, could reduce the likelihood of developing uveitis in a patient with spondyloarthritis, and this included both new onset as well as flares. Those patients who developed the uveitis were those who had a prior history of uveitis. So in actual clinical practice, what do we do if a patient who's already on etanercept develops an episode of anterior uveitis? Some of my patients have developed. What I have done is, if the ophthalmologist has been able to control it with topical steroids, and if it's a single episode, I do not change the biologic. Although some paradoxical uveitis has been described with etanercept. Finally, if the patient develops a very severe uveitis, I might even add methotrexate as an agent to control if the etanercept has controlled the spondyloarthritis very well. However, failing that, I change the biologic. Secukinumab, so far have not had any patients developing uveitis while on secukinumab, but I think this will be the same strategy that I would do. The future has a lot for uveitis treatment. Now, JAK inhibitors in uveitis, there are some case reports of benefits. We already know tofacitinib in AS has gone through a phase 3 study, so we will have the reports. Filgotinib phase 2 study is underway. Baricitinib GIA and uveitis phase 3 trial is underway. Ustekinumab in the STAR trial study for uveitis is underway, and it's expected to complete by 2021. And apremilast in Behçet's is underway. So thank you very much. My apologies if I exceeded my time.
Thank you, Ramesh, for an excellent handling of a slightly difficult topic. I don't see many questions, but the one which is in front of me is asked by Dr. Ankur Dalal. What is the management protocol for idiopathic recurrent uveitis, non-infectious and not associated with inflammatory rheumatic disease? So
when you think, one important thing you have to understand is idiopathic uveitis forms 30% of uveitis. If you look at the division of uveitis by etiology, idiopathic uveitis forms 30% of it. And it is automatically assumed that idiopathic uveitis is inflammatory in origin, and we adopt the same approach of using topical, oral, and disease-modifying drugs.
Another question is there which says, any situation where you would start upfront biologics or DMARDs?
So upfront DMARD, I did give you an indication. If you go back to the focus initiative, it says upfront DMARD where you're going to start. So that initiative tells you where. Upfront biologic per se, not for uveitis. I would go for the underlying disease, but if you're going to be treating the underlying disease with a biologic, then obviously you will take the uveitis into consideration. You might want to choose adalimumab or infliximab as your choice.
There's one more question. How long one should continue steroids in acute attack of uveitis? Oral steroids should always be prescribed along with it, or topical? Well, you have handled it actually.
Yeah, generally it is topical steroids. We don't give oral steroids for everybody. Those with very severe uveitis, with fibrinous uveitis in particular, those who have dense hypopion deposits, those who do not respond to topical. So obviously such people need oral steroids, and there is no set duration for oral steroids. It is as short duration as possible, but from my personal experience with ophthalmologists managing these complicated cases, I look at oral steroids at least for a period of about 4 months.
Dr. Indrajit Agarwal is asking, how long will you prescribe adalimumab in sarcoidosis with uveitis?
So once again, sarcoidosis is a very important inflammatory eye disease. It basically depends on the manifestation of the eye disease. If you are looking at sarcoid granuloma or choroidal granulomas or anterior uveitis, they beautifully respond to methotrexate, which is my first drug of choice. Sarcoid retinitis will also respond very well to methotrexate or sometimes to mycophenolate as well. So we rarely need, but if it has to be adalimumab, then yes, adalimumab does work in sarcoidosis. There is no set duration. So just as much as we are using in other indications, we have to go arbitrarily by giving it maybe for 6 months to a year initially if it's very bad eye disease, and replacing it long-term with methotrexate or mycophenolate.
Now, can I ask you a little awkward question?
Sure, sir.
In juvenile idiopathic arthritis, as we all know, there is an association of uveitis with ANA in the ossiarticular subset. Now, the conditions which have almost 100% ANA positivity, like lupus or scleroderma, it's very rare to see any uveitis in them. So what is so special about JIA that ILR recommends that you periodically screen for uveitis if ANA is positive? So what you have any answer to that?
Maybe one of the pediatric rheumatologists might answer better than because I've stopped seeing JIAs now. But I mean, I only know that female sex and a positive ANA in a child with oligoarticular JIA carries an increased risk of uveitis. Maybe in the Q&As, if there are any pediatric rheumatologists, they could take this question.
Great. Just one more question. Differentiation of tubercular uveitis and HLA-B27 related uveitis in patients with SPA.
Yeah,
on
it's
NPT and
fairly straightforward because anterior uveitis generally causes only simple fine KP depositions, but granulomatous, where you see granulomas, whether in the anterior chamber, mutton fat KPs, where you see dense keratic precipitates sitting, plus choroidal granulomas, plus retinitis. So there is a particular pattern that it can show in TB, but then sometimes, as we know, like how TB is a great mimic of everything else in the body, tubercular uveitis or tubercular eye disease is not easy to recognize. So ophthalmologists sometimes err on MANTO and TB quantiferon gold. And many a times, a lot of the patients with idiopathic uveitis tend to take ATT first. And when they don't respond to ATT, then come on to immunosuppressors.
Well, there is a response from a pediatric rheumatologist that oligo JIA with ANA has asymptomatic uveitis, hence has to be monitored periodically, even though they are asymptomatic. But the question that I had asked was why there is an association? Why in
Can I answer, Dr. Ashok?
Sure.
So the postulated mechanism is that in patients with oligoarticular JIA, you have anti-nuclear antibodies which are predominantly directed against histones, and these histones have a sequence of similarity with retinal S antigen. And that is one of the hypotheses that why they develop uveitis in oligoarticular JIA.
Thank you. I think the other questions probably will have to be answered by Ramesh through email or other means. And we need to proceed to the next talk. Thank you very much. So the last talk in this session is on from bench to bedside, TH3 immunity. And the speaker is none other than Professor Ian McInnes from Glasgow. We all had the chance to listen to his brilliant lecture in Puducherry in Jipmer. And I remember how wonderful that talk was. Now, it is very much in order to introduce the guest speaker. And it's my privilege to say that Professor McInnes is currently the president of EULAR. He holds very important positions in the University of Glasgow currently. And he is, of course, professor of rheumatology. He is a clinician as well as a researcher. And he is director of the Institute of Infection, Immunity, and Immunology. He is also director of Arthritis Research UK Center of Excellence for Rheumatoid Arthritis. His main research interest is understanding of the role of cytokines in inflammatory synovitis. He leads a big clinical trials unit which specializes in the use of biologics in the inflammatory arthritis. He has published extensively in the area of immunobiology and rheumatology. There are lots of PhDs working under him. 35 PhDs have already been completed and there are 20 more ongoing. He currently holds a research grant of more than 15 million euros, you can imagine. And if I look at the awards that he has received, it's a long list, and I would not like to encroach on the time available. And just like to mention that two very important awards that he received recently were, number one, what is Sir James Black Prize Medal, a prestigious award in medicine in 2016. And last year, he was honored with CBE by Her Majesty Queen Elizabeth II. So without taking more time, it is my privilege to welcome Professor McInnes and invite him to give his talk.
Well, thank you so much. That's absolutely wonderful of you. I don't recognize the speaker, and nor does my family, so I'll just step in for whoever that was meant to be. So I hope you can see my slides. It's an absolute joy to be with you. I'm astonished that you are now in the middle of Saturday night in your weekend. You must have very, very uninteresting lives if this is what you want to do at 8:30 on a Saturday night. And for those of you who need to sleep, I'm just going to move over. You'll see my black Labrador has joined me. This is Oliver. He's sound asleep behind me. He falls asleep most times I give a lecture, so he joins me for almost all of the lectures nowadays. So if you need to sleep, just join Oliver and know you're in very good company. But look, it's an absolute joy to be speaking to you this evening. I would much prefer to be with you in person, visiting your wonderful meeting over the last number of years. Has been one of the greatest pleasures for me. But instead, of course, in this strange time of COVID, we have to talk through computers. But I, through the computer, offer you both my own very best wishes, and especially those of EULAR and the EULAR community, and serving as the president of EULAR, I send to all of you the very kindest regards of this time. So these are my conflicts of interest, but also a happier thought. I wish you could come and visit with us in Glasgow. If you're ever bored one day and COVID has gone away enough and you've nothing to do, just come pop over to Glasgow, come and visit us, spend a bit of time. You'll love it. It's a city of culture, it's a city of architecture, and it's a city full of wonderful, friendly people. So if you have a chance, I would love to welcome you and host you here. Right. The other thing about Glasgow is we have a very strange use of the English language. Some of you maybe know this phrase because I have taught this before, but we have a phrase called a hand-me-down, or in Glaswegian, it's called a hon-me-doon. And those of you who are younger brothers or sisters will know that quite often when you were younger, the clothes that you wore were the clothes given to you that were previously worn by your older siblings. In other words, the clothes were handed down. And this, in many respects, is what has been the life of psoriatic arthritis. It has been a life of being handed down. We borrowed drugs from rheumatoid arthritis, the older sibling disease. And it's really only in the last 6 or 7 years that we've started to use medicines in the treatment of psoriatic arthritis that are really derived and developed on the basis of the pathogenesis of that disease. And that's what I'm going to discuss in the context of type 3 immunity. So I'll very briefly bring everyone up to speed on the clinical considerations that we've got to explain. What is the problem? What's the clinical challenge, and how can we as pathogenesis investigators explain that? And then I'll talk a little bit about some cytokine biology. And then the most important thing I'm going to do is I'm going to take you through each of the pivotal phase 3 trial data sets that would inform the use of medicines in 2020. So by the end of this lecture, you should have a single pathway in mind for what type 3 immune pathways are, and you should be able to refer to the major trials that direct our therapeutic decisions. So here's a slide. I think you've seen versions of this slide many, many times before. The range of presentations that occur in people with psoriatic arthritis. Of course, on the left-hand side, you see the classic synovitis, enthesitis, osteitis, skin, nail axis. That's the core of the disease. That's, I think, what all of us are very familiar with. Of course, they don't occur always in all patients, and that's the challenge. We have to decipher these individual subsets. Occasionally axial involvement, and of course, as we've heard beautifully described this evening, I've learned a great deal, thanks to the other speakers for educating me. This is a disease that knows no boundaries in terms of tissue and involvement of the eye, involvement of the gut, and in fact, involvement of the brain, rather common and rather troublesome, particularly as it is often asymptomatic. So the other part of this, of course, is that psoriatic arthritis is almost always a disease of multi-morbidity. And multi-morbidity is defined as the presence of more than 2 or equal to 2 chronic conditions. Now, the reason multi-morbidity matters is that simply being multi-morbid independently reduces the likelihood of being a clinical responder or having favorable outcomes in terms of clinical management. So think about the cardiovascular system, the brain, think about infectious risk, think about osteoporosis, think about the risk of skin cancer, particularly in terms of UV exposure in some treatment regimes. So it's a complex disease. And we're starting to think about it as a spectrum disorder, a disorder that goes from pure cutaneous involvement and a background of obesity, biomechanical stress. We've heard a little bit about HLA-B27, but in fact, there are somewhere between 50 and 80 risk loci already identified across the GWAS studies that have been done. So when you take everything together, this is a spectrum disorder which increasingly we're talking about preclinical psoriatic arthritis, subclinical psoriatic arthritis, all the way through to frank disease. And we may well be treating people at different phases. So this is a Scottish beach. Many of you are not believing me. I know this, but that's because you don't believe that the sun ever shines in Scotland. But actually, the sun is shining today in Scotland. I couldn't say it shines every day, that's the truth. But of course, the thing about a Scottish beach is because we're very far north in the Northern Hemisphere, our tides are very great. So here's an interesting question. Where does Scotland start? Does Scotland start at low tide or high tide? What happens if it's halfway through? When does the Atlantic Ocean finish and the country start? Well, of course, it varies, doesn't it? It's all a matter of when you look. And that's very much an issue of perception. And I think this idea, when does psoriatic arthritis start, is almost certainly and increasingly a matter of the detection threshold. Why does that matter? Well, it matters because pathophysiologically, interventions that we give people with extremely early disease might have disease-modifying potential. And that is a really exciting concept in terms of the IL-23, IL-17 type 3 axis. So just bear that in mind as we go through into the world of pathogenesis. Okay, so that's you knew all of that. You knew about this clinical spectrum, and I hope you're now thinking a little bit about pre-PSA. How does psoriasis to PSA, how does that graduation, that clinical graduation occur, and when does it occur? Is PSA now simply an MRI or ultrasound detection, even if the patient's not aware that they have disease of musculoskeletal system, even though, of course, they have skin plaques? Very interesting question in terms of the future for prevention. So what do we understand about pathology? Well, and this again is a slide I hope some of you have seen before, and I even more hope that you have remembered it from before, because it states a really obvious conclusion. I mean, if you look at the road sign here, this comes from Australia, so no surprise, it has to be very obvious for our Australian friends. Water on road during rain. Yeah. Not a particularly stunning observation, that perhaps. And then on the right-hand side, you see here a beautiful Scottish hillside. The problem being that this is Scotland in the summer, not the winter, and that's why we have an abundance of water. And it's pretty obvious to all of you that Scotland in the summer is likely to be rainy. So an equally abundantly obvious statement is that the disease spectrum takes on tissues with very different immunopathologic roles. So for example, the gut and the skin are barrier tissues, and they are normally infected. We call them commensals. We've heard about the microbiome, beautifully described this evening. That's the normal state for that tissue, and therefore the immune system in the skin and the gut are designed, they've evolved to coexist with microbial insult. On the other hand, the eye, the enthesis, the synovium, we believe are sterile structures, and so the immune response in those tissues is different. It's designed to be different, and therefore there should be no expectation a priori that a given intervention in a particular part of the immune response will brook a similar response in different tissues. It would be perfectly reasonable to understand that immune regulation in the eye or in the enthesis or in the synovium would be different from the immune regulation of the skin or the gut. And so the expectation up front is that we will get different responses in these different tissues as we start to treat different kinds of diseases, and I'll come to that at the very end. Okay, well, I was asked to talk about a type 3 immune response. Some of you are scratching your head thinking, these immunologists, they just keep going on and making more and more and more definitions. Well, of course, the type 1 response, I think you're all familiar with, interferon gamma made by cells that are stimulated by interleukin 12. And what you're seeing here in this balance here is on the outer side, you see the master regulator, and on the inner side, you see the master effector. The upstream regulator cytokine driving downstream effector cytokines. And in theory, you could intervene with any type of immune response by going for regulators or effectors. And you might see different immune dynamics then, you might see different pharmacodynamics, you might see a different rate of response or durability of response. We'll come back to that because that is indeed what we see. So type 1, I think you're familiar with. Type 2, the classic allergic response, evolved for helminth and other worm immunity, but of course now most prominent in our minds as clinicians in terms of the treatment of asthma and atopic dermatitis. And type 3 immunity, the subject for this evening, IL-23, driving the production of the IL-17 superfamily of cytokines. Okay, well, IL-17, and I'm going to talk mainly about IL-17A, but I'll just briefly make mention of its sister cytokine, IL-17F, in a moment. But IL-17A is produced by a broad range of cells of both the adaptive and innate immune response. We tend to think of type 17 cells, but I think we should be thinking more broadly. Now, the reason this is important is that although most of these cells can be activated by IL-23 to produce IL-17, some are activated by other pathways to also produce the IL-17 family. And so the perfect linear relationship that we had previously imagined between IL-23 and IL-17 is not so perfect. Like all families, there are little wrinkles in the story, untold stories, untold truths. And that means that we should not make a conclusion a priori that blocking 17A will be the same as blocking 17A and F, or that blocking 17A and F will be the same as blocking IL-23. And hold that thought for a few moments. And finally, in terms of pathogenesis, what do these cytokines do? Well, IL-23 sits upstream at the top of the slide. It's a master regulator. And in fact, it does so in synergy with TNF and IL-1 beta. It can drive inflammation on the left, osteogenesis, osteoclastogenesis in the center, and enthesitis on the right. And I'm not going to take time this evening dwelling on all of these data. It's Saturday night. The last thing you need is an immunologist talking cellular pathways for 20 minutes. That would be more than the human spirit can stand. So let's just assume that there are a number of cells here at the top of the figure producing IL-17A, its sister cytokine IL-17F, or cytokines with which it works, IL-22 and IL-21. And you can imagine it driving keratinocytes or synovial fibroblasts, driving proliferation, driving leukocyte activation, leukocyte infiltration, driving plaque formation, driving synovitis. You can imagine the same family of cytokines driving excess bone formation or bone erosion imbalance. And that's why this family of cytokines are so pivotal in driving the archetypal radiographic features of PSA, namely osteoproliferation and osteoerosion. And finally, on the right-hand side, you see the pathway leading to enthesitis, the 17A FIL22 pathway leading to chondrocyte hypertrophy, some kind of imbalance of the mesenchymal stem cell axis. What I would direct you particularly to Janice McGonigal's beautiful studies in this area. So on the face of it, these are really fascinating candidate cytokines for driving the type 3 immune response in psoriatic arthritis, and therefore candidates for intervention. And there are now a number of medicines that we use to intervene in this pathway. On the left-hand side, we have drugs that interfere with interleukin-23, respectively ustekinumab, guselkumab, risankizumab, and tidrakizumab. As I always say, you need speech therapy to be a rheumatologist nowadays to pronounce all of these different, really complicated drug names. I have to say the names are much more complicated than the immune biology. So the idea is that they will block the activity of interleukin-23, which activates, amongst other cells, type 17 cells to produce IL-17A, or indeed potentially IL-17F. 17A is blocked by secukinumab, ixekizumab, and 17A and F dropped by a drug called bimekizumab. And I'll show you each of these in turn. And then you could also block the receptor, the IL-17 receptor A. This is confusing nomenclature. That's not a receptor antagonist. That is the actual receptor. And by blocking the receptor, you prevent IL-17A and F, but you also actually prevent all of the IL-17 family members, because the 17 receptor A is rather ubiquitously used. And so you're switching off effectors and regulators at the same time. And that's a subtlety that is often missed. So now let me quickly run you through the clinical data. So the next 10 minutes of your life are a refresher course on the key pivotal studies. And if there are young doctors listening, if you are a trainee and your consultant asks you on Monday, what is the pivotal phase 3 trial for ustekinumab? You're going to say, it's the Summit studies, Professor. Summit 1 and Summit 2. And the Summit 1, Summit 2 trials were published in around 2013, 2014. We published these trials. This was ustekinumab, which is a drug that blocks both IL-12 and IL-23. Now that's a really interesting thing to do, isn't it? Because you remember I showed you a balance of type 1 and type 3 immunity. It turns out that type 1 immunity regulates type 3 immunity. So by blocking both the type 1 and type 3 response, which is what you do with ustekinumab, you may not only blunt the effector response, but also the regulator, and that may dampen the overall benefit. So what we saw in the ustekinumab trials, if you look at the left-hand side, here the ACR 20, 50, 70, was round about half of the patients achieved an ACR 20 and only about a quarter of patients an ACR 50 response. The right-hand side responses were even lower, but this was a very mixed population that included quite a lot of quite drug-resistant patients. We also saw improvements in enthesitis, and for that matter, dactylitis. I'm showing you enthesitis data here. Week 52 on the top from Summit 1 through week 100, and in the bottom, week 52 for Summit 2. So a gratifying improvement in esophageal disease. And the effect on enthesitis is particularly interesting. This is a beautiful study. It's open label, so there are criticisms of its design, but I like it. It's work from George Shett, who does these very elegant trials very often. And what he did was he compared, using a number of different measures, spark, masses, Leeds enthesitis index, he compared the TNF inhibitor with ustekinumab, and you'll see here that the proportional improvement in patients with the enthesitis measures at the top were greater for those patients receiving ustekinumab, suggesting that the type 3 axis may be a dominant pathway in the enthesis. More so on the bottom, you'll see the synovitis responses, where there was really overlap in swollen and tender joint counts, and unsurprisingly, the skin did better with ustekinumab. So we now have drugs that spare the type 1 response. These are the IL-23 P19 inhibitors. The ustekinumab blocks P40, that is a protein that's shared between IL-12 and IL-23, whereas guselkumab, risankizumab, tidrakizumab block only P19 and therefore exclusively block type 3 immunity driven by IL-23. And here's the phase 2 guselkumab study that Atul Diadar and colleagues published a couple of years ago now in the Lancet. In the top left-hand corner, you're seeing the ACR20 responses. And now you can see we're having responses in around 60% of patients. So that's about a 10% improvement over ustekinumab, and around 35% of patients having an ACR50. And even about a quarter of patients achieving minimal disease activity. Now, we've recently published just this year the pivotal phase 3 trial for guselkumab, P19 inhibition. This is work published in the Lancet just 3-4 months ago, the so-called Discover-2 trial. So young doctors, Monday you can dazzle your professor by saying, I've discovered the Discover-2 trial. And your professor, I hope, will be suitably impressed. And if they're not, it's because they haven't read the study yet. Alrighty, what happened in Discover-2? Well, it was a comparison of 2 different dose regimes of guselkumab, given every 8 weeks or every 4 weeks against placebo. And you'll see in the top left-hand corner that just over 60% of patients achieved the, in fact, just above 60%. And if you look at the ACR 50%, ACR 50 responders, and around about 40% of patients. So there were also very gratifying, these are the integrated responses in skin, the IgA response. And you can see large proportions of patients far exceeding placebo, achieving this very nice skin and joint response. Okay, so that's the upstream regulators, and I could have shown you data for risankizumab and tidrakizumab as well, but time precludes me doing that. It's late in the evening. What about blocking the downstream effector part of the type 3 axis? Well, secukinumab is the first IL-17A inhibitor. So it blocks only one member of the 17 superfamily. And the pivotal trial here is the Future-2 phase 3 trial. And it's compared 150 or 300 milligram doses of secukinumab compared to placebo. And you'll see that around about 50 to 55% of patients achieve the primary outcome here in comparison to only 15% of placebo. So the delta here is really very nice indeed. And I think actually the optimal dose of secukinumab is 300 milligrams. Subsequent trials in the Future-2 through Future-5 phase 3 program have really definitively shown that the 300 dose, I think, is the best. And you'll see here that we've got a very nice inhibition of radiographic progression, and it's a drug that works a little better in the TNF naive. Here you're looking at the top ACR20, bottom TNF naive, as opposed to TNF IR populations. And in the TNF IR populations, you see the green and the blue, 300 and 150 doses beginning to separate quite significantly. So secukinumab works. It also works on the dactylitis and enthesitis. You're looking at the former on the left, the latter on the right-hand side. And particularly, again, if you look at 300 milligrams, this is nearly 2/3 of patients with complete resolution of dactylitis through 1 year. So these are impressive and persuasive clinical responses. Secukinumab is not the only IL-17A inhibitor. Ixekizumab, similarly, an IL-17A inhibitor, a very robust medicine that works very nicely in people with psoriatic arthritis. Here is the Spirit-2 pivotal phase 3 trial. Peter Nash published this 2-3 years ago in the Lancet. And again, you're seeing every 2 weeks, every 4-week administration of ixekizumab, comfortably beating placebo. And again, the response rate in the high 50% rate for ACR20 and around about 30 to 40% in the ACR50 regime. So this is a drug that works really very nicely. And again, you see these very robust skin responses. Here's the PASI 100, complete clearance in around about 35 to 40% of patients. And that exceeds anything that we can achieve with the TNF inhibitors, for example. And this is the latest news, isn't it? We now have head-to-head trials. Up until this year, we only really had these indirect comparisons borrowed from the health economic literature, but now we have direct head-to-head data. So here it's the SPIRIT head-to-head trial comparing ixekizumab with adalimumab, 17A inhibition versus TNF inhibition. Now, I want to just focus, stay with me just for a moment here. This was a unique primary outcome in the trial. It was the combination of ACR 50 improvement and PASI 100, clearing skin. That's never been used before in a trial, and in this study, ixekizumab achieved this target in about a third of patients, whereas adalimumab achieved it in only a quarter. This was statistically significant, and the primary outcome of the trial was met. When you look, however, at the ACR 50 rates, ixekizumab and adalimumab were non-inferior. So in the joints, there was no, ixekizumab wasn't any better than adalimumab. Now that's really important to remember. Whereas for the skin, ixekizumab did a whole lot better than adalimumab. And these are the data depicted graphically. You can see change over time for the primary, combined ACR 50 and PASI 100, and the more conventional arthritis measure in the top, really no difference. Skin measure in the bottom, clear difference, again, something we already knew. So I want to bring to you the EXCEED study that we published just a few weeks ago in the Lancet, and this was a head-to-head study of secukinumab with adalimumab. Now, if you look at this slide, you'll see using the pre-specified primary outcome, which was at week 52. So this is a 1-year outcome. SPIRIT head-to-head was 6 months. And you'll see that this study did not make its primary outcome. It just missed it, which was unfortunate in some respects, but it may be giving us regression to the truth. So the primary outcome here was ACR 20. And that, remember, is exactly what we saw in the SPIRIT head-to-head. When we only looked at ACR 20 in SPIRIT head-to-head, ixekizumab and adalimumab were similarly the same. So far, therefore, EXCEED and SPIRIT head-to-head are similar. When you then look at a pre-specified sensitivity analysis, so this was planned all along, but using non-responder imputation, which is actually a very conservative analysis. Ironically, after 1 year, secukinumab was superior to adalimumab. Now, the study missed its primary, so we cannot make any claims, but I think it's kind of interesting. And this is only a 7 percentage point difference, but that might mean something in terms of large number of patient populations. And if you then recreate the SPIRIT head-to-head primary outcome, or as close as using PASI 90 than ACR 50, you'll see here that secukinumab clearly outperformed adalimumab in the skin and overlapped at ACR 50. Again, just around half of patients achieved the ACR 50 responses. Now remember where we were with secukinumab in the Future 2 trial, remember where we were with ustekinumab, remember where we were with TNF blockers. Half of patients with an ACR 50, so the field has moved on. And finally, just before I conclude, what about new kids on the block? Well, I want to introduce you to a drug called bimekizumab. To help you remember, bi, meaning it inhibits IL-17A and F. Now, this is not a bispecific. A bispecific drug is one that has 2 different epitope binding agents on the same molecule. So one binds one part and then a different FC binding is another. So this is a bispecific. Bimekizumab binds a part of IL-17A and IL-17F that are structurally similar. In other words, the reason the drug blocks both cytokines is because the drug targets an important, a functionally crucial part of the 2 molecules that share structural similarities. So that's how bimekizumab works. And here you'll see, and you're not misreading, this was the early exploratory study, an ACR 20 of 80%. And we've now just recently published the phase 2 trial, and I'm showing you here ACR 50 responses just above 50%. And you can see here on the right-hand side, the ACR20 responses. And the dose response is very odd here. We cannot explain that. So be aware that the highest dose group missed its outcome. But the trial itself has shown a really striking 80% ACR20 response. In other words, taking out A and F is beginning to look very interesting indeed. And here you can see the ACR50s over time and the ACR70s on the right. Last couple of things to say to you. Well, what about a true bispecific? Well, the great hope we had was that blocking IL-17A and TNF at the same time, that was going to blow everything out the water, but it didn't. So here's a paper published a couple of years ago now using a drug called ABT122, which blocks IL-17 and TNF. And you can see, in fact, that although there was a subtle bias towards ABT122, there was no really significant differences. So the development of this drug was abandoned. And the last remark, we heard in these very nice talks already tonight about the Janus kinase inhibitors. I was asked to focus on the type 3 axis tonight, and that's what I've done. In theory, the JAK inhibitors may also inhibit the IL-23 axis by inhibiting IL-23 receptor signaling. And this is, if you're interested, I'm not going to show you all the Janus kinase data tonight. Time precludes that. And really, the JAK inhibitors are not individual cytokine specific, so they don't tell us about that axis as I would wish to in a pathogenesis bench to bedside story. But please be aware that we now have positive data for tofacitinib, filgotinib, and at EULAR I showed the SELECT-1 study, that's the pivotal upadacitinib phase 3 trial, strongly positive data. And upadacitinib particularly is very interesting because not only did we see strong articular responses, but we also saw very striking, robust responses in the skin, which was a bit of a surprise, but they're very nice responses indeed. And quite how this works, of course, is uncertain because they probably work through intracellular crosstalk between conventional IL-17 pathways and upstream 23 receptor blockade. So just in summary, what have I told you? Well, I've told you that if you block TNF, IL-17, or the P19 type 3 cytokines, synovitis improves. If you block the axal skeleton, and I haven't talked about that today in the interests of time and focus, it turns out that 17 and TNF are great targets, but IL-23 and IL-12, 23p40 turn out not to be good targets. Different tissue, different response profile. In the anthesis, 17, 23, 12, TNF, all great targets, so too in the skin, but in the gut, IL-17 is not a good target. In fact, if anything, it may even make gut disease worse, although that's heavily disputed. So I'm going to finish with the thought that with these amazing medicines at our disposal now, pathogenesis-driven intervention in psoriatic arthritis, it's really important to consider the place of the patient. This is a slide I use often. Rheumatologists are always the white sheep, the dermatologists are the black sheep, unless, of course, I'm speaking at a dermatology meeting and there's 10,000 dermatologists in the room, then of course the dermatologists become the white sheep and I become the black sheep in the family. But there we are, it's an old English phrase meaning the outlier. Why am I showing this as my last slide? Well, the thing is we've got lots of choices to make now and this can be very confusing for patients. And the next thing we need are a raft of head-to-head trials so that the algorithms that drive our treatments are actually going to be evidence-based. That is now the big challenge. What a brilliant problem to have in the treatment of psoriatic arthritis. We now have choices, and taking those choices forward, ladies and gentlemen, is the great excitement of the next 5 years. Thanks ever so much for your attention. Oliver's still sleeping. If you're sleeping, then I hope you had a jolly good sleep. And if you've been able to stay awake this long, I think you're absolutely wonderful. Thanks so much for your attention tonight. And I'm going to stop sharing my screen and start sharing my happy smiley face. And I'll be delighted to answer any questions that you have. Thanks ever so much.
Thank you, Ian, for a wonderful talk. There are several questions. First of all, a nice compliment from Dr. Mahendranath from Bangalore. He says, Ian, you look handsome and your room is very nice.
Oh, thanks ever so much. I'll tell my wife. All of the fashion housing decisions in my house are made by Karen, my wonderful wife. She chose all of the furniture, and the paintings are original Scottish art. We collect Scottish art, and in fact, over this shoulder is a Scottish This is a Clyde steam puffer ship. And over this shoulder is a Scottish artist's imagining of a Parisian waiter. So go figure. I don't know what it's all about. But
question from Sakir Ahmed is, IL-12/23 blockers work so well in psoriatic arthritis, then why not for it in ankylosing, its cousin ankylosing spondylitis?
yeah, it's a brilliant question. So I think the first thing is we don't know the answer to that question. It's a really important question. I alluded to this in the end. And you could, if I could develop your question and then I'll give you what I think is the answer. You could equally turn it in its head and say, well, why do IL-23 inhibitors seem to work in IBD and IL-17 inhibitors don't? That's an equally perplexing question. Well, I think the answer lies, and I touched on this very briefly, the answer lies in this oversimplification of the cytokine pathways. So we teach that IL-23 drives IL-17, 23 is the master regulator, IL-17 is the effector, and they're always linked like this. But that just isn't true. It's way too dangerous to have a linear cytokine hierarchy. Remember, the immune system's job is to defend us against infection. And if the microbes discovered that by blocking a single unique pathway, it could ablate a whole part of the immune response, then the human race wouldn't have survived. So in fact, the immune regulatory pathways are far more complex. We simplify them for the purposes of drug development. We simplify them. I'm a bear of very simple brain. I don't know if you read the wonderful Winnie the Pooh stories. A.A. Milne talked of a bear of simple brain. That's me. We oversimplify. And what I think is happening in axial disease is that there is IL-23 independent release of IL-17A and IL-17F. So TNF, we and others have shown that TNF and also PAMPs, damage recognition molecules, microstress, will activate the release of the IL-17 family without needing IL-23. In other words, it's a 23 independent pathway. And in the gut, by the way, out of interest, IL-17 is, amongst other things, it is actually an inflammatory molecule in the gut. So blocking IL-17 is anti-inflammatory in the gut. The problem is that IL-17 is also a homeostatic cytokine in the gut. Particularly amongst other pathways, it regulates a molecule called occludin, which does exactly what it sounds. Occludin brings endothelial cells in the gut, epithelial cells, I should say, in the gut together and holds them together. And if you block IL-17 and downregulate occludin, the cells begin to fall apart. And when that happens, you increase gut permeability. That allows, and we heard about this in the microbiome talk, that then allows microbial dysbiosis to occur. And that dysregulates the immune response. So IL-23, on the other hand, doesn't do that. It really does regulate lamina propria inflammation. And that's probably why the drugs behave differently. Brilliant question. And I hope I'll give you a better answer in years to come.
Well, another interesting question from Dr. Ashit Singhal from Chandigarh. He's asking, why is the dose of secukinumab higher for psoriasis than for psoriatic arthritis? One would have thought it the other way around.
Yeah, I think the dose responses for lots of these drugs are just wrong. So if there's anyone, please forgive me if you work in the pharmaceutical industry or the regulators. I've just said something terrible, but yeah, hey, it's late at night, it's Saturday, forgive me. But the problem is that in the real world, I think for secukinumab, the optimal dose is 300, same as in the skin. Actually, psoriatic arthritis is a really difficult disease to choose the right dose. And the reason for that is it's because of, I mentioned the different tissues and the different immune regulatory potential in a different tissue. And I suspect that the pharmacodynamic in skin, enthesis, synovium, gut, eye, is actually rather different for the different molecules. We also have to think about dose delivery. So actually, I think the dose difference in skin and joint, I think that's overestimated by the initial phase 3 studies. I actually think the doses are by and large pretty similar in the real world.
One more question, that IL-17 has been implicated in both RA and psoriatic arthritis, but why bone formation occurs only in psoriatic arthritis? Now, there's some assumption here.
Yeah, that's another great question. Well, here's the interesting thing. 17A inhibition in established RA just didn't work. There was one borderline positive study. That was the study that Mark Genovese published in A&R 3-4 years ago. And actually it was, the ACR20 was in the mid-50s in rheumatoid, but the placebo was in the mid-40s. So I think in established rheumatoid, the IL-23, IL-17 axis is just not functionally relevant. Whereas in psoriatic arthritis, it is the dominant functional regulatory pathway. And that's why we see, we don't really see the bone formation problem in rheumatoid. I don't think that the bone formation pathway via IL-17 and IL-22 is relevant in rheumatoid. The pathways are not expressed sufficiently to drive that reparative process. Now, there's one final thought there, because it might be much subtler than that. It could be that there are actually long-term epigenetically imprinted changes, for example, in the way mesenchymal stem cells are working, or osteogenetic precursors are working in the two diseases. And that's, I think that's an enormously interesting area for us to look at over the next number of years.
I think I'll accommodate just one last question, and that is from Kriti Kishore. Any data on IL-17 inhibitor vis-a-vis apremilast with respect to enthesitis? And also one second part is long-term cardiovascular safety.
Okay, both great questions. First of all, although we don't have head-to-head data, I think when we look at the relative responses, if we anchor them in, we can use the health economic indirect comparator methods. The 17A inhibitors are superior to apremilast, but that's not been proven in a head-to-head clinical trial. But if I have a patient with dominant enthesitis, I would use a 17 or P19 inhibitor before I would use apremilast, to be honest, not least because the cutaneous responses are much more robust. And in terms of cardiovascular risk, well, it's still too early for me to be definitive. What I will say is there's no evidence that there is an exaggeration of cardiovascular risk with the 17 or P19 inhibitors. But I and others have published work showing that there are favorable impacts on surrogates of cardiovascular risk when we inhibit the IL-17A pathway. And at worst, I expect no impact. And I suspect we will see beneficial impact on MACE, the major adverse cardiovascular events. We've certainly published that there is, it looks generally quite encouraging, but we need to see bigger data sets and longer data sets. But it's a very astute question, thank you, because one of my favorite things is how important it is to treat the whole human being and not just the skin and the joints. And again, to the young rheumatologists on this meeting, please always remember to treat the whole person. If someone is overweight, they've got to lose weight. If they have high blood pressure, it has to be treated. Treat the human being, not just the disease that you focus on.
Thank you, Ian, for the wonderful session. Nice answers. And now I would like to hand over to the Secretary of IRA, and this session is closed. Thank you. Thanks.
Thank you, sir. At the outset, I would like to thank IPPA Industries for sponsoring this symposium. I would particularly like, there were about 350 participants at one point of time. We just need to remind everyone that the fourth weekend, Saturdays, Sundays, we have these IRA webinars. On the third weekend, we have the fellows retreat for the fellows. And there are quite a few webinars. I would request all of you to go through IRA so that IRA knows how many webinars are being done so that we can sort of categorize those well and put them up for all of you. Particular thanks to the moderators, Dr. Ashok Kumar and Dr. Dharmanand, Professor Mackins for his brilliant talk. Last year, I remember his talk was one of the best ones at JIPMER. I particularly like the way he talks about two things. One is in terms of, he takes you to lateral thinking, where you start thinking in terms of evolution of human beings. And the second thing is that what he said at the end, that the patients have to be the final goal. And therefore you should, that has to be the final treatment target. Also, Dr. Amita Agarwal for the gutsy talks of Dr. Amita Agarwal, Dr. Varun Dheer and Ramesh Joyce. Tomorrow we have sessions, important sessions, Dr. Nijil Harun, Dr. Ved Chaturvedi, Bhaumik Megnath and Joe Thomas will be doing on their bit on spondyloarthritis. So I request all of you to log in tomorrow again at 6:45 p.m. Until then, all of you stay safe and best of luck to all of you. Thank you.
Thank you.